It's a kind request for all the audience to be seated. He who has health has hope, and he who has hope has everything. A warm welcome to one and all present here. I take this opportunity to address the gathering as we have assembled here for the Cancer Awareness Program on behalf of BHAVANI Memorial. This is a social outreach campaign organized by the Department of Biotechnology and Microbiology, NMKRV College for Women, under the aegis of BHAVANI Memorial Endowment Fund, an alumni initiative in association with KIDWAI Institute of Oncology, Cancer Research and Training Center. I kindly request the chief guest, Y. Tulajappa sir, and the guests of honor, Professor Krishnappa and Dr. Mahantesh from KIDWAI Institute of Oncology, our beloved principal, Dr. Snehalata G. Nadigar, and our vice principal, Dr. Pankaja Nayana ma'am, to occupy the seats on the dais. We kindly request the audience to turn off your mobile phones. We shall begin today's program with the blessings of the Almighty, and I hereby call upon Parimala and team from second year BSc Biotechnology to render the invocation song.
विघ्नराज श्री विनायका वरसिद्धिदायक नमो नमोस्तुते विघ्नराज श्री विनायका वरसिद्धिदायक नमो नमोस्तुते विघ्नराज श्री रत्नखचित मकुटाभरणा रत्नखचित मकुटाभरणा मणिकुण्डलमण्डित कुमार गुरुवर विघ्नराज श्री विनायका वरसिद्धिदायक नमो नमोस्तुते विघ्नराज श्री गकार नाम गणेश्वर गणप्रिय गकार नाम गणेश्वर गणप्रिय गुणानुग्रह गण्यसेवित गुणाकृतिधर गुणपरिपालक मूषिकवाहन मीनाक्षि सुरनुत विघ्नराज श्री विनायका वरसिद्धिदायक नमो नमोस्तुते विघ्नराज श्री विनायका वरसिद्धिदायक नमो नमोस्तुते विघ्नराज श्री
Thank you, Parimala and team. I now request our principal ma'am to welcome the guest and the gathering.
Warm good morning to all the students present here. Good morning. We're all gathered here for this very noble cause and to listen to doctors here under the banner of Department of Biotechnology, BHAVANI Memorial Talk. BHAVANI was our student who succumbed to cancer. Because of her this dreadful disease, the batchmates of BHAVANI and her father, Dr. Vaitujappa, have an endowment on her name. And every year this cancer talk on any of these cancers is chalked up by the Department of Biotechnology. So this is one of the talk of this year. So every year this talk is there on different kinds of cancer. For this I would like to first welcome the doctors from KIDWAI Institute of Oncology, Dr. Krishnappa, HOD Head and Neck Department, KIDWAI Institute of Oncology. Welcome, sir. Dr. Prabha is on her way. She is Dr. Prabha Sheshachar. She is an RMO and palliative care in charge of KIDWAI Institute of Oncology. We welcome her when she comes here. Then we have Dr. Mantesh, instrumental in getting us this talk done. Assistant Surgeon in charge of Cancer Awareness Unit. Welcome, sir. Last but not the least, the main donor, Dr. Vaitujappa, retired professor, Department of Botany, National College, and principal donor of BHAVANI Memorial Endowment Fund. He is also the father of BHAVANI. As you see, her photograph will be shown. I think this screen keeps moving and you will see her photograph. That is BHAVANI. Welcome to all the department staff who are here, the staff of PG, Biotechnology, BBA, and last but not the least, students of BBA, of PG, of Biotechnology, Life Sciences. This is a talk which cuts across all the disciplines. So a warm welcome to all of you. Thank you.
Thank you, ma'am. I kindly request all the dignitaries to light the lamp to mark an auspicious beginning to the event.
आरोग्यं धनसम्पदः
I now invite Dr. Mrunalini Ma'am, PG Coordinator, to acquaint us about the importance of Bhavani Memorial Endowment.
A very good morning to the dignitaries on the dais, my dear students, dear colleagues. Today we have all assembled here to mark Bhavani Memorial Endowment Fund, which was created by the 1994-97 batch biotechnology students in the year 2018 in the loving memory of their classmate, Ms. Bhavani Whitey. The fund is mainly used to create awareness on cancer for our students and the general public at large. The fund is very generously supported by Dr. Y. Tuljappa, father of Bhavani, and her classmates, Sneha Krishna, who is here. I thank Sneha for being here, Smita, myself, Mrinalini, Gargi, Sapna, Priya, Basanti, Prithvi, and her other friends, Kritika, Parvati, and her sister, Purnima Whitey. I heartily welcome Bhavani's daughter, Chaitana, who is amongst us today. And I welcome my dear friend, Jyoti, who is also present here today. So personally, this is a very emotional moment for me. Bhavani was my very dear friend. And as I stand here, I can remember the memories in front of me. We studied in the same college, played in the same grounds, all the sweet memories that we have. One of the reasons was, yes, to remember Bhavani, we wanted to do something and create this awareness fund, but also because Bhavani was a very passionate researcher. So I would like to tell a few achievements of Bhavani. Bhavani Tuljappa Yersime, she did her BSc Biotechnology in NMKRV and an MSc Zoology from Bangalore University. And then she later worked with Dr. K.M. Dinakar on plant tissue culture at St. Joseph's College. She worked as a research assistant in Hydrogen Economy Technology Project at RVCE, worked as a junior production manager in Kode Biotech for about 2 years. Then she was married to Mr. Nagaraj Kuchangi in 2001. She worked as an assistant professor in BMS College for Women. Later on, she did not stop there. She wanted to pursue something in bioinformatics, and she went to UK, and she pursued MS degree in bioinformatics from Glasgow University. She also worked there for a year, returned to India. She has 2 children, daughter Chaitana, presently in 8th standard. Kindly stand up, Chaitana. And son Aditya, who is in 6th standard. But unfortunately, somehow everything came to an end when she was diagnosed with stage 4 gallbladder cancer, and she succumbed to it in 2014. So this is an humble attempt from all of us to keep many more Bhavanis alive. So this is the 4th social outreach event that we are conducting under this banner so that it benefits many of them who are in need. Thank you.
Thank you, ma'am. I now request our chief guest, Dr. Y. Tuljappa sir, retired professor of botany from National College, Baswangudi, and most importantly, Mrs. Bhavani's father, to speak a few words.
Good morning, everybody. At the outset, I thank the RV Trust for allowing us to establish this endowment memorial lecture annually, unhindered. It is as Dr. Murali told, it's an emotional program, because Bhavani, my daughter, We lost her in 2014. As he already mentioned, she had a very brilliant academic career. Just one example I just want to give. When she went to Glasgow University to do her MS Bioinformatics, 12 members when they entered to do their MS, only 3 became eligible to do to get the degree MS. Rest of them were all given diploma certificates. One French, one Indian, that is Bhavani, and the other local UK candidate. That was her merit, that is all. Well, Madam Principal, Dr. Krishnappa, Dr. Mahantesh, we are very proud to have you here to this function. KIDWAI Memorial Hospital is doing yeoman service in the cancer detecting camps here and there. Last year also we were invited here. The department is invited here. And for all these, Suman Madam, and this year, from this year, Dr. Mrinalini taking a lot of interest to organize this function. I thank them very well. And nothing much to say about this because, as I told you, it's an emotional program. Now, we thought in 2014, when she expired due to cancer, gallbladder cancer, we survived for 7 months after identification. And the identification was done when it was in the 4th stage. So no doctor could help on earth. We contacted people, from Chicago, American oncologists. We had video conference with the present here, the doctors in India, to see what best can be done. Because if you wanted to send her even to the station, she could not survive. That's all. Gone is gone. So in that memory, to have her memory all through, we just thought of establishing this endowment. My daughter, who is now in London, major contributions done. As Mrinalini told, a big list of students, her own classmates, donated to their mites to establish endowment. Sorry, not endowment, it is memorial program. I thank the principal of the college, the management, the trust, RV Trust. We are really grateful to this trust because she studied here. And all the teachers were very pet teachers for her. Mainly she used to mention Dr. Nagalakshmi and Madam Suman and her own classmate, Dr. Mrinalini, has come here as a PG teacher here in this college. We are so happy about it. Her own classmate is here to conduct this program very happily. Now, everybody does it. Dr. Madam Suman Madam took a lot of interest at the initial stage, and she's continued to do that, and she's helping Mrinalini to conduct this program. I'm so happy. I'm overwhelmed by this program that is going to be arranged every year, and our mite, just a little amount we have given, up to 3 lakhs, and it's only 2 lakhs something, and we want to make it up to 3 lakhs to conduct these programs very comfortably. That is why the balance of amount, to give this balance of amount, I have brought a check and presenting to the present principal. I think with this 3 lakhs of fund, memorial fund, they can comfortably conduct the programs annually. Only this much I want to tell you. This is not an occasion to give a long speech because we teachers keep on talking for hours together. After having taught nearly 40 years, now I just don't want to do that now. I'm now 80 and I can't do that also. And it should not be boring to the audience. That is the reason why I thank you all very much for such a big number you have joined here. And I thank the authorities, auditors, the principal, the college, the Department of Biotechnology for having organized this function and is going to make a grand success. Thank you very much.
Thank you, sir. I would like to call upon Vishreya RK, student of BSc, second year Biotechnology, to introduce our first speaker, Dr. Krishnappa, to the audience.
Good morning, everyone. Today, we have with us our speaker, Dr. Krishnappa R. Sir, who is the head of the department and a professor in the Department of Neck and Head Surgery at KIDWAI Memorial Institute of Oncology. Sir has also worked as an assistant professor and an associate professor in the Department of Head and Neck Surgery in KIDWAI Memorial Institute of Oncology. He has been an organizing chairman for conferences like OROCON, CME on laryngectomy. He has been awarded the Best Surgical Oncology Head and Amp Neck by KSRTC State Union in Town Hall, Bangalore in 2018. He has also been awarded the outcome of Best Conservation Therapy at a Tertiary Cancer Care Center, Award for Best Poster Presentation at Surgical Society of Bangalore, ASICC, in July 2012. Sir has given a lot of presentations on cancer. He has also published a number of papers on various topics. And with that brief introduction, I request Dr. Krishnappa R. Sir to deliver his talk. We are thrilled to have you, sir.
I kindly request the dignitaries on the dais to take the front row.
We are very pleased to have Dr. Prabha Sheshachar. She is the resident medical officer and the in charge of palliative care unit at KIDWAI Institute of Oncology. She will be delivering the second talk. Welcome, ma'am. Thank you. ಇಲ್ಲ ಸರ್, ದಟ್ಸ್ ಓಕೆ, ಇದನ್ನೇ ಕನೆಕ್ಟ್ ಮಾಡ್ತೀವಿ. ಆಕ್ಸೆಸ್ ಕೊಡಬೇಕು ಅಷ್ಟೇ ಸರ್. ಸರ್ ನಿಮಗೆ ಮೈಕ್ ಇದೇ ಸಾಕಾ ಅಥವಾ ನೀವು ಓಡಾಡ್ಕೊಂಡು ಮಾತಾಡ್ತೀರಾ?
ಓಡಾಡ್ಕೊಂಡು ಮಾತಾಡ್ಬೋದಾ?
ಯಾ, ಜಸ್ಟ್ ಒಂದು ನಿಮಿಷ ಸರ್. ಪೆನ್ ಡ್ರೈವ್ ಏನು ಬೇಡಪ್ಪ? ಓಕೆ ಓಕೆ.
ಹಲೋ. ಬರಲ್ವಾ? ಆ ಕಡೆ ಹಾಕಿ, ಇದಕ್ಕೆ ಹಾಕಿ. ಇದು ತೆಗೆದ್ಬಿಟ್ಟು ಹಾಕ್ಬೇಕಾ? ತೆಗೆದ್ಬಿಡಿ ಅದೇ. ಇಲ್ಲ ಇಲ್ಲ, ವಿಡಿಯೋ ಇದ್ರೆ ಹೇಳಿದ್ರೆ ಮಾಡ್ತಾ ಇದ್ದೆ. ಕನೆಕ್ಟ್ ಆಯ್ತಾ? ಇದು ಮಾಡಿ, ಇದು ಓಕೆನಾ? ಇದು ದಿಸ್ ಇಸ್ ಓಕೆ. ಹಲೋ. ಅದೇ ರೈಟ್. ಓಕೆ. ಗುಡ್ ಮಾರ್ನಿಂಗ್ ಎವ್ರಿವನ್. Good morning. I'm a surgeon, senior surgeon in KIDWAI Memorial Institute of Oncology, in the Department of Veterinary Oncology, where I operate oral cancers, voice box cancers, laryngectomies, thyroidectomies, so many. I thank the organizers, principal, and Dr. Tuljappa. He is my teacher. I just now came to know. He was a professor in the Department of Botany in the National College, where I was a student during maybe 87, 88, sir. I was in a Ramakrishna Ashram, in a Vidyarthi Mandiram. That memories he was telling. Thank you very much, sir, calling me here. What I have planned for you people is, see, it is not just telling about the surgeries. It is about, how to so adrenal cancer is a major health problem in India. Adrenal cancers, like oral cancers, is a globally comprised of 30 to 40% of the global cancer is in our subcontinent, where our Indians, they use a lot of tobacco in terms of gutka, in terms of BD. So it is one of the major health burden to the government to tackle this. So I am in the Department of Veterinary Oncology. We see every year around a new cases, 4,000, 5,000 cases a new year. In a 1 year, we see so many new cases. About 20 to 30,000 cases, they come to our department every month as a follow-up. So according to Globacon, in India, about 28% of cancer cases in male and 7% cases in females occur in oral cavity because of there's a habit of using gutka or kadipudi. See, most of the villagers, our villagers, they use a kadipudi. May I know how many of your friends use this, smoking? Can you raise your hands? Your friends, I am not asking you. No. So any of your family people, your parents, your relatives. So usually our patients, they'll come with a history of, ulcer over the tongue or ulcer in the buccal mucosa. They will come and come in a stage 3 and stage 4. Majority, 80 to 90% of the cases in India, they present in a stage 3 or stage 4. Like Sir said, her daughter presented in a stage 4 disease. So if they come in a stage 1 and stage 2, we can help them with a curative intent. If they come in a stage 4 and stage 3 and stage 4, it will be like a multimodality treatment, and the survival will be very less, 5 years survival. So based on this, see, most of the cases, like in a female patients, the breast cancer is the #1 cancer in India. So if they are aware about how to detect, like personal examination or physician examination, or going to, getting some investigation, mammography, all those things. I think our KIDWAI is providing today, mammography is the X-ray of the breast to detect any lump in the breast. So we can detect early and we treat the patient. Or in the patient presented with a see a lung cancer. How they present? They present with a cough, hemoptysis, chest pain, like that they will present. In the stomach, they present with a loss of appetite, vomiting, passing blood in the stools. So they have to, or mass in the abdomen. If they, usually the stomach is a very expanding structure. So by that time, it will be detected in the stage 4. Similarly, in the pelvic region, where CS cervix or ovarian malignancy, they will present in the later stage, like stage 3 and stage 4. They do not know how the symptoms of the cancer. It is not the patient, problem. The symptoms itself will not tell it is a stage 3 or stage 4. So by the time they come, it will be in a stage 4. So going in that way in head and neck cancers, usually they will also come in a stage 4, not because of it is not seen, or because of the patients are chronic smoker. They are addicted to smoking. They are alcoholics. The alcohol is if they take alcohol, they do not find any pain or any problem. That is the reason most of the patients, they'll come to me. They'll tell, are you a smoker? No, I never smoked. Then if they ask attenders, they will tell, sir, he's an addictor. He takes 1 or 2 packs per day. So similarly, alcohol also, they will tell, sir, I do not smoke. So that is how our patients, they will present it to us. Coming to the world scenario, see about 890,000 cases, roughly 4.5% of all cancer diagnosed all over the world as oral cancers. If you take in the world scenario, but in India, it is the #1 cancer. About 30% of the cancers are oral cancers. So about 450 lakh people, they die every year. So we can target this kind of patients. So how they present? Where in the head and neck, the cancers will be seen in head and neck. Is it on the tongue? Yes. Tongue is #1. Commonest subsite in the oral cancer is on the tongue. Then the buccal mucosa, on the gum, on the palate, on the lips, on the tonsil is called as oropharynx. Then in the hypopharynx. And voice box, larynx, nasal cavity, nasopharynx, behind the nasal cavity, the nasopharynx. These are the commonest. Then comes the cancers of the thyroid. In the neck, the patient usually present with a swelling in the neck. In the middle, in the central region, it will be so thyroid cancer and salivary gland, the glands which produce the saliva, the salivary glands. Then sarcomas, they are the tumors arising from the bone or soft tissues are called as sarcomas. The oral cavity, oropharynx, hypopharynx, as I said. So these are the subset where it, how these cancers, the subset, it is in a, tongue is the commonest place. Oral cavity comprises of 40 to 50% of the patients. They will come with the ulcer on the tongue. Usually they give a history of, any sharp teeth which causes the trauma. Any ulcer on the tongue which is more than 15 days, you have to get, examined or investigated or biopsied, or some scanning has to be done to rule out is a malignant ulcer or traumatic ulcer over the tongue and on the buccal mucosa. Usually some patients, they'll go to a dental doctor telling it is a loosened teeth because of the tumor arising all around the teeth. So teeth will get loosened, and so there it starts their journey. They will come to the edenic surgeons. So this is how the edenic cancers are commonly in the oral cavity. Then the pharynx, where after, it is a food pipe, it starts in the pharynx and goes into the esophagus. And the voice box, larynx, the voice box, usually they present in the stage 4. So what we do, we remove the voice box. We remove the whatever structures it involves, we are going to remove. So usually what I told you, it is a stage 3 or stage 4, condition they will present. We have to. So what is the etiology? Etiology means how the patient will present it to us. What are the questions we have to go into ask? History of tobacco use. These patients, they'll have a history of tobacco use either in the terms of smoking or in terms of smokeless tobacco, like gutka, something like that. Then the history of alcohol. How this tobacco causes malignancy, we should know. In tobacco, there are about 700 carcinogens will be there. It is not the smoke, it is the carcinogens which goes into the body. And we, along with usually these smokers always they drink. This is the alcohol work like a solvent and dissolves the tobacco and get it absorbed into the body. And these carcinogens will go into the body, into the different parts of the body, like lungs, into the stomach, into the esophagus, oral cavity, even in the pelvic organs, where it causes the DNA damage. The cell cycle, kind of G1 phase, G2 phase, there is a tumor suppressor genes will be there, like P53 gene and RB genes. These genes will regulate the cell division, and whichever DNA which damages or any abnormality, these genes will push these cells into the apoptosis. That means natural cell death. If these genes are absent or some mutations happens, what happens? These cells become autonomous. So there will not be any control over brain control. They will proliferate or divide on their own. So it starts dividing on their own. They become a small mass, and it starts spreading these cancer cells all over the body. So how it spreads to how we call it the stage 4, these cancer cells will travel in the blood into all parts of the body, to the lungs, to the liver, to the bones, to the brain. So wherever this metastasis, the present, they usually put the metastasis into the brain, the patient will present with a unconsciousness, increased intracranial tension. So that is in the stage 4. So these cancer cells become autonomous. They will not under any control of brain control. It starts spreading in the blood into the different parts of the body. So usually these patients, with a history of any dental problems, then occupational exposure also causes some of the cancers in the body. Infections, nutritional factors, inflammatory will go one by one. Okay, how these factors which creates cancer in our body. You should aware of about it. So coming to the tobacco. So tobacco, I said, is a smoking tobacco and smokeless tobacco. What it contains? It contains chemicals. So I said about 30 known carcinogens. IARS, International Cancer Organization, has detected about 30 these chemicals are very highly carcinogens. Like polycyclic aromatic hydrocarbons and nitrosamines are some of the chemicals which causes a DNA damage and mutations where this normal cell will become a cancer cell. So alcohol will add up in this pathology. These are the different types of tobacco. Usually our Indian people, they use the BDs. BD, it is a tobacco powder which packs in the leaves, and this is a smokeless tobacco like chutta, gutka. What are the contents of the gutka? See, gutka contains the aracanate, again it is a carcinogen. Then sun-dried, roasted, finely chopped tobacco with the flavorings and sweeteners they will add and give as a sweet, pan, pan, kaina. These are some of the, and kadipudi. Kadipudi is a, our, when we were in a village, even our grandparents, they used to have a something is called as tina ena ಹೇಳ್ತಾ ಇದ್ರು ಒಂದು bag contains kadipudi. Whoever comes to the house, instead of giving coffee tea, they used to give ele adike kadipudi. In a day they used to 5 to 10 times. They do not calculate. If I ask my patient how many times you were using, usually my patients, the age group of 40 to 70, 80, 90 years. That is the age group we see. Majority are males nowadays because of this gutka and all those things. Old ladies also I see, old grandparents, they will bring at the age of 80, 90 years. If they ask, illappa ella bitbittidini, bittu sumaru varsha agoytu. Sari, ನೀವು ತಿಂತಾ ಇದ್ರಲ್ಲ, ಅವಾಗ ಎಷ್ಟು ತಿಂತಿದ್ರಿ ಹೇಳಿ ಅಂದರೆ ಒಂದು 10-15 ಸಾರಿ ದಿನಕ್ಕೆ ತಗೋತಾ ಇದ್ವಿ ಅಂತ ಹೇಳ್ತಾರೆ. ಇದು ಕಾಮನ್. ಇಲ್ಲಿಂದ ಅಲ್ಲೋಗಿ ಕೂತ್ಕೊಂಡ್ರೆ ಒಂದು ಸರಿ, ಅಲ್ಲಿಂದ ಇನ್ನೊಂದು ಕಡೆ ಕೂತ್ಕೊಂಡ್ರೆ ಒಂದು ಸರಿ, ಯಾರಾದ್ರೂ ಬಂದರೆ ಒಂದು ಸರಿ. ಸೊ ವಾಟ್ ದೇ ಯೂಸ್ ಟು ಡೂ, ಕಡ್ಡಿ ಪುಡಿ ದೇ ವಿಲ್ ಕೀಪ್ ಇಟ್ ಇನ್ ಒನ್ ಸೈಡ್. ಇಲ್ಲಿ ರಾತ್ರಿ ಎಲ್ಲ ಮಲಗಿಬಿಡೋದು. ಇಟ್ ಇಸ್ ಅಡಿಕ್ಷನ್. ಓಲ್ ಡೇ something should be there in their mouth. So what happens, whichever side they use, this kadipudi, that side usually they'll present. Then comes to alcohol. I think so nowadays, if you go to Koramangala, night at 2 o'clock, lot of these girls who are working in IT company are walking around in the night life. They call it as a night life. For my son, I went to some, for his birthday. We were there till 11 o'clock. Then I asked one of my wife's cousin is in Koramangala. He said, Anna, ನೀನು 2 ಗಂಟೆಗೆ ಬರಬೇಕು ನೈಟು. ಏನಿರ್ತಾರೆ ಇಲ್ಲಿ ಗರ್ಲ್ಸು ಅಂತ. So, that is a night life. They drink, they, it is, make lot of money because of the IT, staying in the PG. So, I'm not blaming only girls. Among 5 boys, 1 girl will be there. So, these are the, how this alcohol acts as a solvent, dissolves the tobacco, all the chemicals would get into the body. Also some acetaldehyde, and upregulates the enzyme in the liver. So, and decrease the activity of the DNA repair enzymes. That means that all the tumor suppressor genes. So that will be suppressed. And of course, immunity. very important is our body. We should be very fit. See, our sir, Tuljappa is 80 years. I cannot believe he's 80 years. So fit, and you should, every day we have to, so you should know your body, science, how our body ages. We are all crossed 50. Now we are compulsorily, we have to fitness, we have to do morning, evening. Maybe as the age, we cross 50, 60, we become very, fitness freak, and we, do 1 hour every day morning walking. When we were young, we never bothered about this fitness, all those things. So whatever friends, they take us, go to MG Road, see all the movies, when I am Bangalore Medical College. I realized after my MBBS is over, I got a degree, I do not know where to go. Should I go to a village practice as a medical officer? No, then I decided it is not the end. Then we started studying. Actually, my studies started after my MBBS. So where to go? We studied, those days entrance exams were there, not the NEET like exams. So we got into good medical college. After Bangalore Medical College, I went to Hubli Medical College, KMC Hubli. So God's grace, we got a chance to work in KIDWAI, where we see lot of suffering patients. You can help them. We are not helping any patient. We are doing our job actually. Whatever job we got, we are doing our job to the patients. Most of our patients are free patients, like BPL card holders. Our KIDWAI is treating with a free of cost for all the patient. Whichever patient comes in a BPL card or any other government card, we are treating. It is a cashless treatment. I think Madam also accepts, or Mahantesh is in a Vajpayee scheme. He clears the, it is a government insurance. In one day, he will clear whatever case surgery I want to do. I want to do robotic surgery. I want to do a laser surgery. Or whoever is a VIP, comes from influence from the Vidhan Soda, or from teachers like your college calls me, sir, it is my servant or my relative, please help me. Immediately we admit and we do our treatment. So we do not differentiate. If you bring more influence, I will keep him in the outside my room. I do not entertain that patient. So that is how we want to help. Every patient is the same. It is different if you work in a corporate hospital, where we try to convince them, get treated so that I will get some, surgeon charges. It's not like that. KIDWAI is a place where it's like a temple. One of my teachers, like Dr. Nanjundappa and Dr. Shanai, I know Dr. Prabha Madam also, she is in a palliative care. Most of the surgery, cases which beyond the 4th stage, beyond, there is no treatment. Neither surgery nor chemotherapy, radiotherapy will respond to that, stage. Those cases will go to madam. So how to treat this patient? They will suffering with the pain, vomiting. They are not able to breathe. Everywhere tumor is there. Every parts of the body tumor is already it is there. So such kind of cases, we refer to madam, our department, palliative care, pain and palliative care. So all these brands. So I will not go into that. So then few not very these dental etiology. Maybe sharp teeth can cause a traumatic ulcer, and that ulcer, if they do not go to a dental doctor to get tooth extraction or some, that ulcer will over a period of time can convert it into a malignancy. Very important, oral hygiene is also very important. So, and dentures also can, one of the etiological factor. Then occupational exposures, people who are working in the industry area, the pollution, wood, people working in the wood dust, chemicals, These are the some of the contains chemicals which creates causes malignancy in the nasal cavity, in the nose, in the nasopharynx. Over a period of time, if they work in that dust, that dust will go and sit on the cells. So those cells will get a very important aspect is the infections. How this infection, what kind of infection will cause a cancer? Have you heard about recently there was a news was there some Pandey. What is her name? Some Sonam Pandey. So Poonam Pandey, not Sonam, Poonam Pandey. So the lot of news people they came to me, sir, give a one about this. Why they were so interested on Poonam Pandey? I do not know. But there were rumors of there is a cervical cancer. She has got a cervical cancer and she died. That was the news. How this cervical cancer in younger people they'll come? Is because of human papilloma virus infection. This human papilloma virus infection, what are the risk factors? How it spreads in a younger female? So this human papilloma virus again, it spreads in a woman with a young girls or boys, early sexual contact, unhygienic sexual contact, and whoever is infected with HPV infection, get contact with them, so it will spreads from one person to other person. So this virus is, it is a very good place to grow in the either in the oral cavity, oropharynx, or in the cervical region. These cells, epithelial cells, squamous cell carcinoma we call it as squamous cells it will help the virus to get into the cells. So this virus proliferate there and it has got a E6 and E7 proteins in the virus. It will damages the, as I said earlier, tumor suppressor genes like P53 and RB genes. When these genes will mutations happens, the cells converted into normal to cancer cells. So that's how this human papilloma virus will create a cancer either in the cervical cancer or in the oropharynx. This cancer is very common in the Western countries. Not very common means adenoid cancer I'm telling. Oropharyngeal cancer like tonsil, base tongue cancers. They will have a HPV positive cancers. In India because of bad hygiene, so many other things. Now it is coming control. Earlier it is number one cancer in India. Now it is because of the awareness, the vaccination. People are aware about this dreaded cancer. So it is coming down. Maybe in the future, it may be like in Western countries. Cervical cancer is reducing now. But oropharyngeal cancer, it is increasing in the Western culture because of the some unnatural sexual behavior. So then what is the other viruses which causes cancers? Like HIV infections, there the immunity will be very it will go down. What happens, these virus, when the immunity goes down, there is a Kaposi sarcoma, not only Kaposi sarcomas, so many lymphomas also will appear in the HIV patients. The other one is human HCV viral infections also causes some skin cancers. And this is a very important slide. It contains antioxidants, vitamin A, vitamin C, and vitamin E. These are the cancer fighting, fruits, vegetables. We have to take more vegetables, fruits, which contains these vitamins and antioxidants, rather than going for junk foods. Like, most of them you people like pizza, burger only. No? Now my children always they order pizza and burger only. If you prepare, nobody eats homemade food. So that is not correct. You have to go for this, good vegetables and fruits. So it will protect our body. Not only protect our body from all the, not only cancers, cardiovascular, lung diseases, your whole body will be, if you take vegetables and fruits. Then come to the iodine. low iodine causes the thyroid cancers, low iodine. So any patient comes with a swelling in the thyroid region, middle of the thyroid, papillary carcinoma thyroid, follicular carcinoma, these are the types of cancers they will present it to us. Then what are the inflammatory diseases which can cause malignancy? Like gastroesophageal reflux disease, a gastric problem. Some people, the diabetic patient or some elderly patient, obese patients, they will have this kind of gastric problem always, in the stomach. The HCl, the hydrochloric acid, this upper ear or digestive tract, very sensitive mucosa. Now, whenever the patient, they'll come, sir, ಸ್ವಲ್ಪ voice change ಇದೆ ಸರ್, ಯಾವಾಗಲೂ throat pain, sir, ನೋಡಿ ಏನಾದ್ರು ಕ್ಯಾನ್ಸರ್ ಇದೆಯಾ ಏನು ಅಂತ, they will come to me. So we put a mirror examination or endoscope examination, you will see. Most of the time, 99% of the time, the mucosa will be congested, it will be looks very red because of the food habit. They want to eat always the mirchi, capsicum, bhajis, ಕಬಾಬುಗಳು ಅವೆಲ್ಲ ತಿಂತಾರಲ್ಲ, ಏನಾಗುತ್ತೆ ಜೀರ್ಣ ಆಗೋದಿಲ್ಲ ಅವ್ರಿಗೆ. ಮೋಸ್ಟ್ ಆಫ್ ದಿ ಗರ್ಲ್ಸ್ ದೇ ಲೈಕ್ ಇದೇ ಫುಡ್ ಅನ್ಸುತ್ತೆ ದೆನ್ ಲೈಕ್ ದ್ಯಾಟ್. ಸೊ ದಿ GERD ಆಲ್ಸೋ ಕ್ಯಾನ್ ಕಾಸಸ್ ಕ್ಯಾನ್ಸರ್ ಇನ್ ದ laryngeal cancer. These pre-cancerous conditions like white patch in the oral cavity, white patch, or it's called as a leukoplekia. Erythroplakia is a red patch in the buccal mucosa or oral cavity, anywhere in the body. And one more condition is oral submucosal fibrosis because of the tobacco chewing habit. They will have a bands, they cannot open the mouth. They cannot open the mouth. It will be, trismus will be there. Because of these bands, chronic use of this tobacco, the mucosa, the collagen will be, increased, the bands become very hard and they cannot open the mouth over a period of time. It is very common in our subcontinent. We cannot visualize what is the problem, So these are some of the pre-cancerous conditions which can convert into malignancies. About 3 to 20% of these leukoplekia, erythroplakia conditions, and these bands can convert into malignancy. So anybody in our house or any of your, if you find any white patch, in the oral cavity, apart from fungal infections, it should be get investigated. Then what are the genetic? Is it hereditary? What are the genetic conditions which can convert into malignancy? Yes, there are few are there. Like Leigh-Fraumeni syndrome, it is autosomal dominant condition. Again, it is a mutation of the gene. Then Fanconi's anemia, Bloom syndrome, ataxia telangiectasia. There are some of the conditions where thyroid malignancies are seen in these conditions. Also, 4 to 6% of these cancers have a like this oropharyngeal cancer. A young female come to me age of 20 years, no history of tobacco, no history of any alcohol, comes with a history of dysphagia, means there is a difficulty in swallowing. She cannot swallow even liquids also. If I do endoscope and see, there is a growth in the cricopharynx, that is the starting of the esophagus. So there is no history. ಏನು ಇವ್ರಿಗೆ ಹ್ಯಾಬಿಟ್ಸೇ ಇಲ್ಲ ಸರ್, ಆದ್ರೂ ಎಂಡೋಸ್ಕೋಪಿ ಮಾಡಿದ್ರೆ ಕ್ಯಾನ್ಸರ್ ಇದೆ, 20 ವರ್ಷ, ಓನ್ಲಿ 20 years. ಸೊ this some of the Plummer-Wilson syndrome, Patterson-Brown-Kelly syndrome is the one condition where the patients will have a low HB. The hemoglobin is 4 or 5 grams per cent. And some other symptoms will be there. They will present like this. Usually these cancers also, if the immunity or their nutritional status. Nutrition status is very, very important. You have to maintain your good nutrition. So one of the syndrome where low nutrition can be. And other cancer which strong, with an esophageal cancer where there is genetic and environmental factors will affect, like Gardner syndrome, multiple polyposis, Cowden's disease, multiple endocrine MEN syndrome, we call it as a MEN syndrome, where again the genetic damage in the DNA will have a medullary thyroid carcinoma, even in the age of small kids also. From the small kids to elderly age, they will have a medullary thyroid carcinoma, thyroid cancer. Of course, osteosarcoma is a bone tumor. Then sarcomas is a other soft tissue tumors which can have a, they have studied, in this, maybe biotechnology people, they are interested to study our Indian Institute of Science also, they come to our institute to study the tumor markers and how this tumor will develop in a normal cell. So these are the syndromes. Coming to the immunological factors, as I said earlier, the HIV infection is one of the condition where they will have multiple cancers during their period. Also some organ transplantation where they give a lot of steroids and immunomodulator drugs they'll give. They can cause these cancers. So what are the endocrine disturbances in a women where the early menarche, in nulliparity, or age of full-term pregnancy at the elderly pregnancy? They are the risk of breast cancers. More of breast cancers are more in these conditions. Why the Western kind of food habits, life structure, they don't want to children, they don't want to breastfeed, they don't early age of men, all these conditions more of towards the breast cancer rather than our head and neck. Of course few have a list. Now coming to the radiation, what is this radiation, which one of the reasons for the malignancy in the head and neck region, and maybe previous history of radiation therapy, like a second malignancy. See, the one patient comes to you us with the oropharyngeal malignancy, we'll give a radiotherapy over a period of time. Usually the patient, if it comes in stage 3 and stage 4, they'll die within 1 or 2 years. These people. Some lucky patient, they'll survive. They survive for 10 years, 15 years. So those patients, they'll come for regular follow-up. We are right now at present we have a PET scan. Earlier we do not have that scan. We used to do some CT scan, ultrasound scan. Wherever they tell, sir, we have got a chest pain, we'll use to investigate anything is there in the chest. Or abdomen pain, we investigate any metastasis into the liver or something like that. Now we have got a PET scan where it will detect whole body scan. They'll give a one radio material that will go and sits in the tumor. That will looks like a red color in the CT films. So we can detect where and all it has, metastatic into the different parts of the body. So they will have a history of, accidental nuclear power plant. Recently it is happened in the, it will happening in the USSR like earlier. Chernobyl is one area where there is a nuclear, catastrophe was there. Also now people wanted to use their nuclear weapons. So low dose nuclear weapons maybe they are using. What we use in the medical treatment, very small fraction of radiation we use it for a treatment. That is 50 to 70 gray. The grays we use. We do not go beyond the 70, 75 grays. That is the medical for treatment. If it goes beyond 1000 grays or something like that, they will have a, it all bodies, children, we should not give more than 20 grays. So where the children, they'll come with the brain tumors, they'll come with the ALL, means acute leukemias, lymphomas, younger children, they do not have any history of anything. This is hereditary or some, changes, genetic changes in their cells. They'll come in the stay in our KIDWAI for 6 months, for a treatment. Of course, thyroid is one of the gland which is more prone for radiation-induced malignancy. How these patients presented to us? How they come to us? They'll come with a history of a chronic non-healing ulcer in the oral cavity, either over the tongue or over the, they cannot chew, they cannot swallow because of the ulcer. Now, as it ulcer grows, stage by stage, the symptom starts. Now, if it involves the nerves, there is a pain, radiation pain into the ear. So now about 12 cranial nerves comes from the brain into our head and neck region. Whenever these nerves will involve, the pain will be radiated into that side of the head. They will come with the history of headache, sir, idu tumba tale nota ide, kivi nota ide. But his problem is in the throat. The tumor will be in the hypopharynx or in the oral cavity that causes radiating pain. Then feeling lump or foreign body sensation in the throat because there is a tumor is growing inside. They do not know. They always will 1 or 2 quarter of alcohol they'll take, and every day they smoke Now, whenever they drink, they smoke a lot. No, they will be in a high, this nicotine, what it is there in the smoking, that's what they want. Actually, they do not know so many carcinogens are there in the smoking, no, cigarette or this one. They want nicotine. But recently, the Western countries, they came out with the e-cigarettes also. E-cigarette is also not safe. So they become addicted. All the bodies will, immunity will go. These chemicals also will be there, very toxic. Whatever the e-cigarettes, they will have a lot of toxicity. It will also cause us cancers in the body. Then comes the difficulty, as I said, difficulty in swallowing. To such an extent, they will come to us, complete block. No, they do not come in an early stage. See, usually we say, sir, that gattal nota ide, in madadu, we get a mirror examination endoscope. The kind of cases they come to us, complete block. There is not a drop of water is going down. That is how our social, economic problem, social factors. Nobody is there to bring that patient to the hospital. No, he is a working person. One person will be there, he will go for a coolie. He will earning is 500 to 1,000 rupees. If he comes to our hospital 1 or 2 days, we will manage this one. See, that's why the government is giving a free rice for those people. No, to my KIDWAI, people will come with iPhone, come with a Innova car, they will show I have got a BPL card. They don't want to spend 1 rupee. Like recently I had a fight with one person. He's got all 10 fingers gold rings. Full gold. He is asking admission. Already we have treated for his father-in-law. We have done a surgery free, given a radiotherapy free, given chemotherapy free. Now, almost after 3-4 years, he's got a recurrence now. He wanted admission. He does not want to keep him in his house. He wants admission, hospital admission. Where I have to give? I have a 40 to 50 patients waiting outside for admission. For one bed, we get around 20 to 30 patients are waiting. Such is our institute. It is the number 1, number 2 in the country, in the country government sector. Ours is the best cancer institute in India. It was, came in the week magazine, National Week magazine. It came number 1 as a government center. And I think the top 5 is there, namdu, if you compare all the private. See, ours is like a red bus. Ours is like a red bus. We have to wait. The private hospital is like a Volvo bus. Sleeper coach. But you have to spend lakhs of money. Where is the money for our patients? 500 rupees is a very big money for them. Now, if you ask one CT scan, earlier, before the was the Vajpayee AEGIS stream has come, earlier we were there. I know madam is also here. To get a paracetamol, it was difficult for them. If I ask to get a CT scan, they will disappear. They never come to a hospital only. Now everything is free. First word I will say to our patient attenders, free treatment is there. Just you come, we'll treat. We will treat. The life of the patients as well as the attenders will become easy for them. Otherwise, it is very difficult to take care of a cancer patient at home. They will ask, sir, is it a transferable? Is it makkalu mommakkala joteli irtare, then obrinda obರಿಗೆ spread ಆಗುತ್ತಾ? No. It won't spread from one person to one person. Why should I work in a cancer hospital then? Since 20-25 years I am working. So it is the cells which changes from normal to cancer cells because of the tobacco, alcohol and other factors. So they will come with a worseness of voice. It won't stops there. They will come with a stridor. Stridor bole to there is difficulty in breathing. If you put a mirror examination, all of the vocal cord where the air goes into their lungs, it will be blocked because of the tumor. To such stage they will come. We make a tracheostomy. We will bypass the airway, doing a opening in the lower part of the, below the tumor. And we do some investigation, scanning, all those things. We stage the tumor. We counsel the patient. This is what treatment we are going to give. If they agree, then we do surgery, depending upon the patient condition. If the patient walks into our hospital, we give all sorts of treatment. If the patient comes in a wheelchair or on a trolley, she will not tolerate any of the treatment. So I refer directly to the Prabha madam. Let her take care of this, bedridden patient. So they will take care very well with morphine or whatever the pain management. They will take care of the patient very well. Then what are the other, like lump in the neck, like thyroid malignancy? And sometimes it bleeds. Bleeding tumor, very difficult to, how to control the bleeding in the throat. If the bleeding outside, we can put a pressure, we can control bleeding. We cannot control inside. They will die. Many patients, they died in front of my eyes. When I joined KIDWAI, in the first week itself, I saw a stage 3 patient on hypopharyngeal malignancy. I asked some investigations. Then second day, I got a call from the treatment room. Patient is in the bad condition. I went there, it's bleeding. Full of throat and nose everywhere. The blood is, he cannot breathe. He died in front of my own eyes. We do not have some equipment those days, was not there. Suction operator was not there. Some of the instruments, now it is well equipped in our center. Earlier it was not there. A lot of people, people like our Tuljappa sir, a philanthropist, they will come to our KIDWAI. They will donate. They donate some of the equipments to the extent we have to thank Dr. Sudha Madam, Infosys Chairman. She has built a OPD block, costs around 60 to 70 crores. They have donated OT theaters. Lot of people, there is a countless donors, they are coming to KIDWAI. They are donating and they are making our patients, to see that they will get all the whatever modality of treatment, either in terms of chemotherapy. It's very, very costly chemotherapy drugs. We are giving free of cost because of the donors or government schemes. So, nasal block obstruction, because the tumor in the nasal cavity, it will obstruct the nasal cavity. That's how they'll come, or bleeding from the nose. Put in an endoscope, we can see the tumor. We'll take a biopsy, do a CT scan, stage the tumor, and we treat based on this one. So these are some of the clinical pictures. See these clinical pictures. Nobody wants to see in the beginning of any multiplex. If you go, they will show this video. Remember any multiplex? It is a government has made it. It is a public awareness. That's how these patients will come to, hospital. In my clinic, the see, this is a ulcer over the lateral border of the left side of the tongue. Maybe it looks like stage 1. And this is a buccal mucosa growth, where she was using the kadipudi on that side over a period of years. So it is ulcer is developed. Now she not able to open completely. Now if you leave this one another 15 days, it completely mouth opening will be. And see the kind of, it's almost a stage 4, involving the bones, going beyond our visibility. We take a CT scan, we stage the tumor, we completely remove. I will show the specimens. This is how the external appearing of the ulcer over the cheek and the palate. Okay. This is the same tumor which is seen on outside. Okay, it is going into intratemporal fossa towards the brain. Sometimes these tumors come with an intracranial extension also. Of course, this. So, this is the thyroid malignancy. The thyroid swelling will be in the center. Okay, so usually younger females, whenever there is a hormonal, deficit is there, TSH, the brain will send the signals to the thyroid gland, produce more thyroxine. So it starts proliferating. It will sometimes be goiter. It will be a goiter, multinodular goiter, or sometimes. If it turns out to be malignancy, then you have to do needle examination. Then we have to. But this nodule sitting on the trachea or vocal cord, it can compress the trachea. Then voice can change. And these are the specimens we remove after surgery. This part of the, we remove. What to do for that defect? Half of this face will remove. What to do? It is not a tailor shop where we can put some cloth over there. It's a human body. No, what we cannot replace with that functioning organ. If I remove the whole tongue, I cannot replace with the functional tongue. Only I can put a free flap or some other muscle or skin where it sits there and seen as some tissue is there. That's all. It won't work like a tongue. It won't work like a buccal, gum or something like that. This is a composite resection. This is called as a composite resection, where the half of the mandible we remove with a tumor, and the neck dissection where it is spread into the neck, and in that place we do a PMMC flap or some free flaps. This is along with the skin we have removed, and this is how the patient are seen later on. Whole life they will be like this only. Or saliva will be drooping from the side. They cannot eat normally, liquids and all. And sometimes if the stage is a smaller stage and you'll have a very good, it will be better surgery than this one. See, this angle of the mouth is gone. That is where the tumor arising on over the both upper lip and lower lip. Half of the lips we have removed. So, what to do? This kind of cases. The prevention. Prevention is the most cost-effective strategy in the long term of the cancer. So there are 4 levels of prevention: primordial, primary, secondary, and tertiary prevention. This is more important for you people. How to prevent among in the society or in your friend circle? How to educate? How to know about it? How to prevent this? Primordial prevention is the government is going to take this primordial prevention. Like, national policy in discouraging the use of tobacco, alcohol, araconate, all those things. They'll, all the cigarette packs they have banned the, tobacco advertisement. They have, put on the cigarette pack it is causes injuries to health, or it can cause, many things. The government is making to prevent the emergence and establishment of the social, cultural, economic patterns of living that contribute to an enhanced risk of this disease. The children are the best suitable population to target this type of prevention. Children, like you people, you should know aware about what will happen if the cancer, appears in your family or somebody like that. Of course, primary prevention, early detection, is to limit the incidence of disease by controlling the causes and risk factors, the primary prevention. After 5 years of quitting smoking, what happens? The risk of oral cancer decreased by up to 50%. And it approaches the level of non-smokers at about 20 years of quitting this smoking. So risk of oral cancer with alcohol is also reversed after 20 years of abstinence. It is, some elderly people they tell light alcohol will be, protects our heart or something like that. But alcohol, which is addictors, every day morning without smoking, without alcohol, they cannot go to a toilet also. They cannot go, it won't come down. They should have one, cigarette or BD in their mouth, then only they'll go to toilet. Otherwise, it won't come. So that is the addiction. Okay. All, mood elevating will be there. After they take the nicotine, it goes into the brain and secrete the dopamine, and that will create the body a lot of changes. So they feel, thing like that. With just 2 to 3 minutes taken by clinician, shown the change in the attitude, knowledge, and behavior of the people towards the tobacco. This is some of the papers they have, published. For people, they can listen to our, advice. They do not listen. If somebody says, you go and say to somebody, you stop smoking, they will tell, no, ನೀನೇ ದುಡ್ಡು ಕೊಡ್ತಾ ಇದೆಯಾ? ನನ್ನ ದುಡ್ಡಲ್ಲಿ ನಾನು ತಗೋತಾ ಇದ್ದೀನಿ. That's what they say. Most of our village people, they will fight with the children. They'll go out of, their house. They stay separately. If they put a conditions, don't smoke, don't drink, they'll, that is how they are addicted to such kind of things. There is some organization is there. Voice of Tobacco Victims is a non-profit organization working in India, comprising cancer survivors and motivated oncologists all over the country. They are doing voluntary advocacy with the policy of makers and the powerful tobacco industry. And this campaign has played a chief role in the pan-India Gutka ban, increase the taxes on the tobacco products, and decline in the volume of sales of chewable tobacco and cigarettes about by 20%, 20-26%, not completely. And our EDNEC, we have an association, the International Federation of Head and Neck Oncology. Last week I was in Chennai, where our, there is a IFUNOS meeting was there. Surgeons from New York, the MSKCC, Dr. Jatin Shah and his team, they came. They are the people since the last 20 years, they are traveling all over the world, and to India is Dr. Jatin Shah and Dr. Ashok Shah leading, they are spreading the treatment of head and neck cancers. So either by surgery or radiotherapy, chemotherapy, they have association. And we have the Indian Association, Federation of Head and Neck Oncology. And I am the organizing secretary for the 2025. We are hosting the national conference, bringing around 1,000 surgeons, oncologists, everyone into the Bangalore. And, it is educating the younger generation of surgeons, how we are transferring our knowledge to their younger generation, how new things, new surgeries, new robotic surgery, laser surgeries, results of these surgeries, we are showing our results and spreading into the younger generation. So they have, society has declared July 27th as a World Head and Neck Cancer Day because of the oral cancers. On the occasion of its 5th World Cancer Congress in New York. Coming to the secondary prevention, it includes early detection, where go to door. Some of the studies have done many pioneers in India. So early detection of cancer through screening programs in individuals who are asymptomatic. They do not know what is a lump in the breast, is there or not in there. At the age of 50, 60, they don't want to, examine or go to a doctor, get examined, or they don't want to tell. There's some problem is there in their, chest. So such kind of people are there. They don't want to get examined also. If you go to some villages for a camp, madam knows, many people, they do not come for a pelvic examination. So that is the kind of things are there in India. They should come out of that. It includes early detection of cancer through screening programs, individuals who are asymptomatic or at high risk, as well as prevention of malignant transformation of oral pre-malignant lesions, where I said leukoplegia, erythroplakia, some of the pre-malignant lesions, white patch, anywhere in the body, either in the cervix or in the oral cavity. You should get investigated, get biopsied. We have to see under my microscope, is it the malignant cells are seen or not. If it is seen, we have to take a treatment, or else what happens, it will start spreading all over the body. Oral cancer is an ideal model for screening. Why it is ideal? Because it can be seen. Everybody can see in the oral cavity. You can see on mirror. You can detect anything, any abnormalities there or not. We cannot make out in the stomach or in the lungs or in the pelvis, unless. So the treatment of oral cancer at early stage achieves increased survival rates and decrease the morbidity. It is a diagnostic case. Say for example, if a patient comes in early stage, any cancer anywhere in the body, stage 1 and stage 2, we can cure. We can cure. Okay, if it is a stage 3 and stage 4, then survival decreases. Say for example, if it is a stage 1, the 5-year survival rate is around 90%. You can survive 5 years. At the age of 60 years, 70 years, you will have without any symptoms, without any burden to the family, you will survive for 5 years if you get treated. With the stage 3 and stage 4, survival comes down to 10 to 20%. Maybe you can survive only 1 year. After surgery, radiotherapy, chemotherapy, this treatment itself takes around 6 months. So you will survive another 6 months. A cluster randomized trial involving 191,873 subjects in southern India, where in Kerala, done by Shankar Narayanan. His paper is very popular all over the world. So they have done, volunteer organization, went to go door to door with the social workers. They want to detect, put a toluidine blue. See, is there any patch? Is there or not? Refer to district hospital. There they'll do a biopsy. If it confirms, they will treat. Okay, so showed after 15 years of follow-up and 4 rounds of screening, there is a statistically significant decrease in the incidence of cancer by 38%, and mortality, death rate decreased by 81% in that part of the country. So this has shown to be the most effective strategy and lead to improvement of survival and stage shift across the whole population. That's why all these screening programs, all these camps, what we are doing all over Karnataka, our KIDWAI got a lot of centers are there. Our Madam and Dr. Mahantesh, they go to different parts of the state. Any district, any place, if they arrange one screening program in there, our team will go. So they will see all the patients are normal people. Few patients, 1 or 2%, they'll have a history of the symptoms. They'll refer back to KIDWAI. We give a free screening, free test, scanning, biopsy, surgery, everything we give free of cost. The gold standard for screening is visual examination, wherever it is. Either endoscopy examination, direct visual examination, which has a sensitivity and specificity of about 98%. So we can detect early diseases and treat at the earliest so that their quality of life will be best. You take, for example, Yuvraj. You take, for example, cricketer, Yuvraj Singh and Sunil Dutt. They are diagnosed and treated. Now they are normal. So if they are detected in early stage, they can have a normal life. If they are detected in a late stage, heard about Anant Kumar? He was a central minister. Anant Kumar, he was central minister. They have their own hospital, Shankar Hospital now, and Rangadhari Hospital. He detected within a few months he died because of the stage 4 disease. I will always give an example. These people, even if you have got a crores of rupees, you come to me with a stage 4, I cannot do anything. They will ask, I have got billions of dollars. When I went to America, one person is a billionaire. Where I was working under Madhuri Madam, Dr. Madhuri Madam, she was a pain and palliative care chief. She was treating this pain management. That patient is someone around 70-80 years. He is presented with a prostate cancer with all over the bone metastasis. Severe back pain because of the metastatic tumor. He is telling, I can spend millions of dollars. I don't want this pain, I cannot tolerate. See, nothing will be there in our hands. The tumor, if you come in that stage, that's all. It will not listen to our treatment. Sometimes, whatever you do surgery, radiotherapy, chemotherapy, it will recur. They will come with a second malignancy. They present with the distant mets. So, detect early. Prevention is the gold standard. Screening program is the gold standard. High-risk individuals should be regular mouth self-examination. Those who had already had a history of the smoking, they have left the smoking and all, they are high-risk patients. A lot of people, they'll come to me in a private hospital where I practice in Maya, Jayanagar. They'll come to me, sir, I had a history of this, smoking. Now I left almost 10 years, 15 years, small white patches. They are concerned about it. So I do a small brush biopsy or so these are the various diagnostic modalities, to screening in head and neck cancer. Put a toluidine blue or lugalcidine. See what is the blue color changes. Then you take a biopsy or do brush biopsy or tissue fluorescence imaging. There are so many are there. DNA analysis you do, or your biomarkers. With that biopsy you can do the tumor markers. And excision biopsy, if it is small lesion already is there, excise it, send it for some good labs. They will see under electron microscope and they will give what is the tertiary prevention? Of course, this is an effective initial management of oral cancer with improved survival has led to emergence of second malignancy. What I am speaking, second malignancy. Okay, they will have upper ear or digestive tract. They already history at 10 years, 20 years of history of tobacco use. They came to me with a history of the sear tongue. All the chances are there they can develop one more malignancy. What happens before They're getting a report, they will disappear from, you do a surgery, remove the tumor, it is healed. So it will take 10 to 15 days to get all the final report. They will disappear. They do not come. You leave the further adjuvant treatment. Adjuvant treatment bola to, after definitive treatment surgery, we have to give radiotherapy and chemotherapy. They do not take. They'll come back with another one within 1 year with a small, big lumps in the neck. Already there is a last stage. They will tell, sir, ನಮ್ಮ ಮನೇಲಿ ಯಾರು ಸತ್ತೋದ್ರು, ಯಾರು ನಮ್ಮ ತಾತ ಸತ್ತ, ನಮ್ಮ ಅಜ್ಜಿ ಸತ್ತ, ಬರಲಿಲ್ಲ, ಅವ್ರು ಸಾಯೋದಕ್ಕೂ ಇವನಿಗೇನು ತೊಂದರೆ, ಇವನೇ ಕ್ಯಾನ್ಸರ್ ಪೇಷಂಟ್, ಈ ಶುಡ್ ಕಮ್ treated completely, full treatment, multi-modality treatment, surgery, chemotherapy, radiotherapy. He has not completed his treatment. So this is what the tertiary prevention regarding the second primaries. There's a higher chances of recurrence and second primaries in individuals who have continued to smoke. We remove the completely voice box, we remove. What happens? There will be a hole, will be the tracheostomy. From this hole, he has to breathe. He cannot breathe through his mouth or nose. From here, he started smoking. This wall, from this wall. That is how our people are addicted. What are the take-home message from this presentation is, the adenoid cancers are rapidly increasing in our Southeast Asia, India, rapidly increasing present year because of the tobacco and alcohol, because of Western culture. So both tobacco and alcohol act synergistically. They act together. If you drink more, you smoke more. Like that, it is a more cancer you get. So as well as independently, both with the direct association between number of pack years, how many packs you smoke and how many pegs you drink. Out of all risk factor, tobacco is the most extensively studied. About 70 to 80% of the adenoid cancer are linked with the tobacco smoking. So prevention is the best and most cost effective. So for a patient, we spend around 15 to 20 lakhs in our patients. 15 to 20 lakhs, surgery, radiotherapy, chemotherapy. If you go to Apollo Hospital or in a Fortis, they charge 7 to 8 lakhs for a surgery. 5 to 7 lakhs for radiotherapy, chemotherapy is very expensive. So it is the most cost effective strategy for long-term control of the cancer. Thank you.
Any queries from the audience?
You can ask any doubts, questions. Anybody wants to ask any questions, doubts? Please. Our madam will answer because ಅದು ಅರ್ಬುದ ಅಂತ ಕರೀತಾರೆ ಅಲ್ಲ, ಕರೆಕ್ಟ್ ಮೇಡಮ್? ನಿಮಗೆ ಕನ್ನಡದಲ್ಲಿ, ಹಿಂದಿನಲ್ಲಿ, ಇಂಗ್ಲೀಷ್ನಲ್ಲಿ ಏನು ಡಿಫ್ರೆನ್ಸ್ ಏನು ಆಗೋದಿಲ್ಲ. ಕ್ಯಾನ್ಸರ್ ಈಸ್ ಎ ಕ್ಯಾನ್ಸರ್, ಆಯ್ತರಾ? ನಮ್ಮ ಕಿಡ್ವಾಯಿ ಅರ್ಬುದ ಸೆಂಟರ್ ಅಂತಲೇ ಕನ್ನಡದಲ್ಲಿ ಕರೀತಾರೆ. ಬಟ್ ಇಟ್ ಇಸ್ ದ ಕಿಡ್ವಾಯಿ ಮೆಮೋರಿಯಲ್ ಇನ್ಸ್ಟಿಟ್ಯೂಟ್ ಆಫ್ ಆಂಕಾಲಜಿ ಅಂತ ಯಾಕೆ ಕರೀತಾರೆ ಅಂದರೆ, ಒಬ್ಬ ಕಿಡ್ವಾಯಿ ಅನ್ನೋರು ಗವರ್ನರ್ ಆಗಿದ್ದರು ಇಲ್ಲೋ ಬಾಂಬೆನಲ್ಲಿ. ದೇರ್ ಆನ್ಸಿಸ್ಟರ್ಸ್ ಆರ್ ದೇರ್ ಇನ್ UP. ದೇ ಹ್ಯಾವ್ ಡೊನೇಟೆಡ್ ದಿ ಲ್ಯಾಂಡ್ ಆ್ಯಂಡ್ ಬಿಲ್ಟ್ during our MBBS time, the KIDWAI is a dumping center. Like whenever there is a cancer is there, they used to dump here like a, Karnastraya, Atara. Nobody knows how to treat. That was the problem. No surgeon knows how to treat, how this tumor behaves. There is no cancer medicines were available in India, and very few radiotherapy units were there in India. One of the center was Adyar Cancer Center, and it was there very small scale, primitive stage. Now that has grown to level. During 1981, it became an autonomous center under government of Karnataka. Dr. Ramakrishna Hegde has shown very, he has donated a lot of funds to our center, and Dr. Krishna Bhargav, He was our director that time. He has worked day and night and to build such a huge center. And recently, Dr. Ramachandra is our director. He's transformed our KIDWAI into from government hospital to the level of beyond our corporate. If you come and see our cancer center, it will be better than any corporate hospital. So you have every equipment we have. Robotic we have. We will do a lot of robotic surgeries, laser surgeries, all the equipments we have. So come anytime you people want to come to my department. I will show the patients how they sufferings. You can have any other questions? No? Thank you.
Sorry. Due to paucity of time, we can discuss this later with sir. We have another speaker waiting.
Thank you.
Thank you, sir.
Thank you, sir, for giving us the awareness on the head and neck cancer, oral cancer, cervical cancer, and knowledge on carcinogens. Also, thank you for giving us the awareness on medical methods used to treat cancer and how to prevent them. Thank you, sir.
Thank you, Shreya. I would like to call upon Ms. Swati Lakshmi, student of MSc First Year Biotechnology, to introduce our second speaker, Dr. Prabha Sheshachar.
Good afternoon to one and all present here. Myself, Swati Lakshmi from first year MSc Biotechnology, extend a warm welcome to Dr. Prabha Sheshacha, a resident medical officer whose illustrious career spans an impressive 29 years in anesthesiology and palliative medicine. Dr. Prabha Sheshacha's dedication to the field is exemplified by her extensive qualification, including an MBBS, DA in anesthesiology, PGDHM in hospital management, and diplomas in acupuncture. Not only she is a seasoned professional in her field, but she also is a national faculty and a course head for Indian Association of Palliative Care, playing a pivotal role in shaping the future of palliative medicine. Her expertise has garnered her an international recognition and won her several accolades, including a Best Paper Award at an international conference held in Hyderabad. Her commitment extends to combating tobacco-related cancers and highlighting the detrimental effects of alcohol, embedding a holistic approach to healthcare. Please join me in extending our heartfelt appreciation for invaluable contribution and unwavering dedication for betterment and healthcare. Welcome, Dr. Sheshacha, and thank you for inspiring us all with our exemplary work and unwavering commitment to excellence. Thank you.
A very good morning to each one of you here. And I really feel honored to be part of this tribute for our beloved Bhavani Madam, as Sir's beloved daughter. And I think it's one of the best ways to have an awareness program, to have somebody at the back of us who are watching us and feeling happy that she has been the cause for having this awareness program, and thereby we would be reducing the number of cancer cases in society. So thank you once again for inviting me over here. I think after the extensive discussion about cancer from a doctor, Krishnappa. I think it's a very, very important topic that everybody should know the awareness and how the cancer starts. Tobacco-related cancers are very, very common. Though people have reduced cigarette smoking, but still it's rampant in many areas. And I think he brought it out beautifully, very practically, down-to-earth issues for all of you to understand how cancer causes. But my topic today would be a little more at an emotional level, because I think we need to sensitize everybody to see what goes through a patient, what emotions go through a patient when a cancer has been diagnosed. Now, somebody asked, what is it in Kannada? Okay, don't ask me what is palliative care in Kannada. I will still try to stutter and struggle over it. But earlier they used to call it as a Novu Nivarane Center, and then it became palliative care, and the word palliative care is coined by Dame Cicely Saunders in the UK. So anyway, we'll be going into it. Why is it becoming an emotional topic? Is for us to realize that earlier or even now, when a patient is diagnosed with cancer, what happens to the family? What happens to the patient? I think it's anyone's guess. You must have seen it in movies. It's a huge shock for the patient, isn't it? They do not know what really hit them. Many of them don't even know what cancer means, especially when they're coming from rural areas. The word cancer also, they wouldn't know what it means. They've only been told that it is some kind of a disease, that we have brought you to this hospital and hopefully that you will get cured. So they are there with the intention that I have come here to this hospital, some disease is there, one kaile agide, nan guna agtini anta. They feel that they'll get better and they'll go back home. But they may not know the real truth. They may not know the real truth that the stage they come in, 80% of our patients who are coming in to our hospital are coming from rural areas, and they would have already crossed the stage of third and fourth stage, where it is very difficult for us to even promise them cure. It is very difficult, but we still try our best to see what can be salvaged. And then we make a transition from the curative intent to the palliative care intent, so that their lives will be peacefully led, make them improve the quality of life, make them live with dignity, and then die with dignity. And that is what we're concentrating on. When he said they come with fourth stage, we cannot do, then they send them to the palliative care department. We take on such patients and ensure that the rest of their lives, however long it is, whether it's 6 months, 1 year, 3 months, we ensure that their life, they lead a very as close as normal and improve the quality of life and ensure they live painless and they live peaceful till the very end. So that is our intention of this. Now I'll probably show you some pictures. I didn't want to put a lot of text in my slides. I thought I could illustrate the entire thing through pictures. So can I have the next slide? Somebody's operating for me there? Oh yeah, the pointer is there. Sorry, I hope I can see that. Which is the one for the next one? This one? Okay. All right, when you see this patient, what crosses your mind? He's a cancer patient. But what crosses your mind? Any one thing? His position, the way he's sleeping. Pain, yes. He must be suffering with pain, right? This position also, does it tell you something else? He's given up. So madam says he's almost like he's given up. A sense of hopelessness, right? Helplessness and hopelessness. Anything else? You can speak out loud. I know you girls can scream when wanted. Right? Talk loudly. Right, wrong, don't be bold. Must be depression. Excellent. Must have gone into depression. Yes? Yeah, he wants to get detached from the world. Yes? See, now it's coming up. What are you feeling now? You're beginning to feel what the patient is feeling, isn't it? Anything else? Okay, more or less, let's go, because I don't want to take too much time. Now here, this patient is a 36-year-old patient with a cancer in the stomach. He's operated 2 years ago. And right now he complains of severe pain, obviously in the stomach. He's got a lot of vomiting and he has sleepless nights. All right. And he's the only sole bread earner of the family. And he's got a wife and 3 children. So you can just imagine the family scenario. And obviously from the way it looks, he must be coming from a rural area. And what does he think? I should not have taken to alcohol. Okay, am I dying? Who will look after my family? Can you do something to save me? Now, what are all his problems now? Guilt, yes. Guilt. Frustration. Regret, excellent. Regret. Pardon? Responsibility. Now he's worried. Now he's responsible for the family. Who's going to take on the responsibility of family after I die? And most of the women don't work outside. They're housewives. So how do you earn the money for? So now it's coming out. Now you're looking at the other angle of a cancer patient, right? There are doctors who treat the cancers. But what happens to the other aspects of the cancer patient? Who's going to look into it, right? So now you see the same patient. Is it just the physical pain they suffer from? It's not. Your physical pain is pain, vomiting, lack of sleep and all that. The other one is social pain. Too weak to work. Loss of job. Loss of finances. Isn't it? And there's so much of psychological issues. Fear, anxiety. Fear comes when? When they're dying or when they're diagnosed? When they're diagnosed also, when they're dying also. But the 2 different kinds of fears are different to different circumstances. We can discuss that. Uncertainty, guilt, hopelessness, regret. You know, so many things. So psychological issues are lots in these patients. Lots. Spiritual, why did God do this to me? Isn't it? So many of them keep thinking, no, why? Why me? Even he smokes, even he drinks. He's healthy, but why was I chosen to have this cancer? Am I being punished? Okay, those thoughts start coming to him. Am I being punished? What was my past karma? Am I paying for it in this generation, in this life? All right? So all these physical, psychological, social, spiritual are called total suffering. They're called total suffering, or they're called total pain. So when you talk about pain, it's just not physical, it is psychological, social, as well as spiritual, emotional. All that is the pain. So we have to take the responsibility to ensure that all these areas and all these 4 dimensions are looked into when you're actually treating the patient. Should I be only treating the patient? The patient, the moment the patient walks into the hospital, whoever's treating should look into these 4 domains, but may not be to an extent because they're too busy, but at least identify they're suffering from something that needs attention, right? Now, Dr. Krishnappa has shown you quite a few pictures which look a little gory, correct? Head and neck cancers can be very gory when you come to the hospital and see. He's invited you all. For you to know the real picture about when you get a cancer, what happens. Now, head and neck cancer can look very alarming because it's so visible, whereas the rest of the cancers you don't see. So this CA stomach you couldn't see. Oh my God. This is a cancer of the buccal mucosa. Now, why am I showing you the picture? I'm not telling you the treatment part. He's already discussed that. I'm only trying to let you understand this patient. What do you think the patient is going through? Obviously pain, right? He has a lot of pain. But along with the pain, there's a lot of smell that is generated there. Nobody likes to go near the patient. All right? And mind you, this patient, he's been abandoned. He's been left in the hospital for us to look after, and they didn't turn back to fetch him. He's been left with us, and he said we cannot take care of him at home because we have a very small house. People don't come. People don't socialize. They feel all of us have got cancer in this hospital, in this house. So they've left them here. You see the Ryle's tube that he's got? It's a tube that goes into his stomach from the nose. Why is that? Because he's unable to open his mouth. He's unable to chew his food. We need to keep him alive. All right? And it has affected his vocal cords as well. So he's unable to speak. So you look at the number of problems that he has. He cannot eat. He cannot speak. He's got severe pain. It's foul smelling. He's abandoned. A sense of rejection. My family people don't want me anymore. He's unable to express his feelings. And he's lying there on the bed. What do you want us to do? 4th stage cancer. We can't give up on him because we have decided that he has to live a life with dignity and die with dignity. Okay, how can you help him? Can you help him? Right? So we did whatever we could. We cleaned up his wound, ensured that the smell comes down. We gave him pain management. We fed him with whatever, but he could not express what his thoughts are. So we had people to come and sit by him and just talk to him. He couldn't even write much. But whatever hand movement he did, we could understand. We only said, it doesn't matter. Please forgive your family members. They also have problems to take care of you. But they have entrusted you to us because they know that we can take care of you the best. So forgive them because he'll be so upset with them. Forgive them, forgive them. Okay, we are here to listen to you. We know what's happening to you. We are there with you till the very end. Just to tell him that we are there with you is so much better. Feels so much better, right? So palliative care practices needs a heart, your attitude to the patient. Anybody who takes up this subject, you should change your attitude. Whatever you do, you say, whatever I can do, even if it's 10%, I will put in 10%. For him, it's 100%, a change in his life. Okay? Knowledge, of course, we learn a lot on how to improve the skills and your hand skills. So this is a definition, and it is a very long definition. What they're trying to tell us, palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness. Is cancer the only life-threatening illness? AIDS is a life-threatening illness. End-stage cardiac disease, end-stage renal disease, right? As well as geriatrics, that is care of the elderly. All these people require palliative care. And what you do, you work through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychological, social, and spiritual. Okay. Who is this? Ashoka the Great, right? Why is he here in palliative care? He's killed so many people. The concept of palliative care, or we call it the hospice care. Hospice is nothing but a home-like environment, but it's a hospital kind of setting, giving a home-like environment. That is a hospice. This concept of hospice care or palliative care was not new to India. It had started at the time of Ashoka the Great. Why? I hope you remember your history. I'm sure history must be still going on here. Kalinga War, right? At the end of the Kalinga War, Ashoka became a changed man. He adopted Buddhism. But what did he do? Why palliative care? He saw the bloodshed, people dying. He immediately constructed small homes for them to be taken care of. And he knew they were all going to die, but he wanted them to have a dignified death. I can't leave them in the war field like that. Let me take them inside these inns, care for them, clean their wounds, dress their wounds, give them some pain relief. Let somebody be there while they're dying. All these things had already come within him. He just changed his attitude and then he adopted Buddhism. So the concept of palliative care is not new to India. But this person is called Dame Cicely Saunders, Dr. Dame Cicely Saunders. Now she coined the term hospice care or palliative care in UK in the year 1967. A very interesting story of Dame Cicely Saunders. Now that is the hospice that she has constructed. Dame Cicely Saunders was a social welfare person, a social worker. And she actually nursed a lot of patients. But then she said, I want to do something more than just nursing them as a social welfare officer. So she decided to study nursing. So she did that subject and she became a nurse. So she got herself admitted to the hospital, enrolled for her nursing program, took care of all the patients, but she was not allowed to prescribe medicines. She knew her subject very well. Her knowledge was really great. But because she was not a doctor, she was not allowed to prescribe drugs like morphine. She knew that they all required it, and the availability of doctors were a little scarce. So she decided to do medicine. She studied medicine and then became a doctor. Then she had the small hospice that she constructed. Now it is a little larger. And then there was one patient who got admitted. She cared for that. She cared for a lot of patients, but there's one particular patient, a man, whom she really took care of, and then she fell in love with him. He's going to die, but still she fell in love with him. He fell in love with her, and then they got married. And before he died, he gave her whatever amount he had, gave it to her for her to expand the hospice, because he knew her passion was there. So they expanded the hospice. It's in London. And if you can see the first picture, I am standing there. I had the opportunity to go and visit this hospice. And of course, she's no more. But then he gave her the amount and told her that I will be a window in your house. So that's a promise that through me, you're going to look into the world and see whatever they require. Let me be that instrumental in your life. Right? So Dame Cicely Saunders' philosophy was, you matter because you are you. You matter to the last moment of your life. And we will do all that we can, not only to help you die peacefully, but to live until you die. It's such a profound thing to know that till the very last minute, we're going to take care of you. I can give you umpteen examples. Like there was a nurse in our hospital, and there was a lady with breast cancer. She had a huge fungating mask with maggots. Maggots are those worms that sit. And she was going to die probably in 2 hours or 1 day maximum. She had excruciating pain, and she'd come directly from the village. We took her on. And somebody said, Bitpidu, yeah, okay, she's going to die. What are you trying to do? Leave her alone. But she was screaming with pain. We said, no. Immediately we gave her pain management. She had foul smell. We removed all the maggots. And this one particular nurse, she had so much of compassion for this. She did everything possible. She had the raw papaya. She learned there was a raw papaya when you can put on it and remove all the smell. She did that. She dressed her. She made her look cosmetically good. And then the next day she died. But before she died, she said, you have really taken care of me, and I feel so comfortable. Now I don't mind going away from this world now. I know I've got what I wanted. And then she died. So it's just a matter of a day. But how satisfying it is for us to give her that kind of death. Isn't it? Okay? So that is what we all try to work at. So what Dame Cicely Saunders say about good palliative care is something that if I learn, I can give it to my own kith and kin. I can give it to anybody around me. So this is what we need to learn. So she says palliative care is nothing but total care, which is physical, psychological, social, and spiritual. Okay? Now, what does this mean, this particular slide? When do we start palliative care? Dr. Krishma said that once fourth stage is over, then we send them to madam, she will take care. Palliative care starts from the time we diagnose, because the way we break the news to the patient itself has to be done in a very, very sensitive manner. There is something that we teach most doctors, breaking bad news. So the impact of the bad news comes down. And also the family members, right? See, palliative care is just not looking only at the patient. It's including the family members. A patient gets cancer, the entire family feels they've got cancer. The whole family has gone into dooms, right? So we need to address the family issues, help the patient cope with the illness, right? Right from the start, with the diagnosis, through the treatment, because the treatment have a lot of side effects. People leave in between and run away home. We have to be very, very supportive to them till the very end, so that the transition from the curative intent, and then finally when they say, no, we've done enough, and looks like we cannot treat you anymore, it has already gone to fourth stage, right? So the transition from there to palliative care becomes a little smoother. So that is why it's important for us to start right from the start. The patient walks into the hospital, we start palliative care along with them so that they can get the best of the treatment. And we also say that there's death. Even beyond the death of the patient, we give palliative care. To whom? To the family members, to help them carry on with life as normal as possible. We have to identify grief in them. There's something called pathological grief, which they don't get over even after many years. Right? So we need to be very, very supportive to them till they're able to manage themselves. So that's called bereavement care. So palliative care can be done by a team of people. Can I alone do it? No. We need a team of people. And the team of people, the treating doctors, nurses, specialists, name it, everybody is there. And then finally, if you can see the last one, is called the volunteer. And who's a volunteer? Who can be a volunteer? Anybody from a small child to a grown-up person can be a volunteer. An old man can be a volunteer. You can be a volunteer. And how can you help? I have trained about 300 volunteers coming from schools, colleges, retired bankers, IT people, in all various areas that they can help out a patient who requires palliative care, right? So now these some of the things, I don't want to go into details, but yeah, some of the things you can identify, psychological issues are shock, fear, anxiety, uncertainty, guilt, anger. A lot of patients who have come with anger, denial, sadness, fear of death. What is fear of death? Why everybody is afraid of death, but what about the death they're afraid of? It's more the process of dying. Am I going to choke and die? Am I going to have a lot of pain and die? How is my process of dying? They're very, very afraid. So we need to talk to them and counsel them. And altered body image, just like what, and why me? Why me is always something that they go on feeling about. Of course, this is disease management. So the worst thing to say to a patient is, there's nothing more we can do for you now. You can take him home. That's the worst thing to tell. To cure sometimes, to relieve often, and to comfort always. That should be our motto. To comfort always. Give hope to the patient. What kind of hope? We cannot really give hope of cure to everybody, but you can give hope to prolong his life, give hope to relieve his symptoms, give hope for a peaceful death. In all this, the way you communicate to the patient is very, very important. And most important element of communication is what? Listening. Just listening to them is a very, very important aspect of communication skills. So in total, palliative care is an active total care, provides relief from pain and symptoms. It affirms life, but it regards dying as a normal process, intends neither to hasten or postpone death, and integrates the psychological and spiritual aspects of patient care. I think all of this I need not tell you. Courtesy, not patronizing, being honest. I think these things are all inbuilt with us. And who can benefit? Cancer, HIV, muscular dystrophies, chronic lung, all these people can benefit with palliative care. And why I'm talking about this, care of the elderly. You only think palliative care to be given to people who have got a disease, who have got an illness. But geriatric care, this is called geriatric care, or it's called care of the elderly. I'm sure most of you here have parents and grandparents who are old, could be frail, and they require care. And if you give them all 4 dimensions, they also have physical issues. They have psychological issues. Agree? Not agree? Agreed. Psychological issues, social issues, spiritual issues. All of them have it. They all have it. And we need to address all of that. So most of them will have the feeling of loneliness, depression. They require help even to stand up and sit, even to walk. We need to be sensitive to all of it. And unfortunately, in some areas, if the old people really do their regular work, I feel sometimes it's good. They'll have some exercise. But then, pushing them to do some hard work, like that a man over there, I think it's quite inhuman. So we need, as a society in large, should be taking care of the older generation who are out in society. It's just not your parents or grandparents. You see anybody on the street who are old, unable to do things, please lend your support to them. And where can you give palliative care? It's just not in the hospital. It can be given in the hospice. It can be given in homes. It can be given by you. Right? So these are some of the pictures of doctors and the nurses and our pharmacists. And these are the volunteers who really come up and help our patients. You can give them psychological support. You can run errands for them. You say, maybe I'm not trained for giving psychological support. You can run errands for them. You can cook for them. You can play games with them. We have a lot of people who come and play games with the pediatric children, clowning and things like that. It makes them feel good. There are a group of people who come and teach the patients, the children who have missed school. So that is also a voluntary thing. So you can take up anything to volunteer. Just sit by the side of the patient and hold the patient's hand. That itself is good. Makes the patient feel good. Okay? These are also some more volunteers. We also have rehabilitation for the spouses of the patient who being passed away, so that we can rehabilitate them, do them skill training so that they can go back home and earn out of it. So we have volunteers also who help us with skill training programs. So you can be a volunteer. So the end, we add life to the last few days for a patient who's dying. We are here to provide comfort, maybe not a cure, for the family, not just the patient. For the entire family, they require palliative care. And we are here to add years to life, to improve the quality of life of the patient. And we all know that you have the potentials to do it. Please open your mind towards this and come forward. We will give you a lending hand for that. Thank you so much.
Request the speaker to stay, and does the audience have any queries? They can address the speaker. Thank you.
Yeah, please. Yeah, you need a mic? Yeah, absolutely. This question, we also, not only me, even Dr. Krishnappa, and he says, no, he's overburdened. All of us need debriefing for ourselves. We're also, when I started palliative care in the beginning, I'm basically an anesthetist. I have given anesthesia for more than 20 years, but I was practicing palliative care along with pain management. Then I completely moved to palliative care because I realized there is a need for it, somebody to look into it deeply. Yes, I had many episodes, many times when I have been crying, go back home and cry. But I said, no, if I cry and run away, then there's nobody else who's going to volunteer to be a palliative care person. That is something that we have to think. Change, see, I'm also a very emotional person, but yes, it takes a lot for us to draw a line where we should ensure that we don't cross it. I always tell everybody, my doctors who are getting trained under me, love your patients, but love them to the extent that you don't, Don't cross the line that you start feeling for them and start crying for them. You have to draw a line there. You have to talk to yourself and say, it's okay, I have done my bit. But debriefing, definitely, we also require.
Hats off to you, all doctors, for doing this consistently on an everyday basis.
Thank you so much. Thank you, thank you.
And my second question is, how does one enroll to become a volunteer?
Yeah, voluntary program is, in fact, Christ College also, I had a lot of students, they had it in their curriculum to, for the social service that they need to do compulsorily. But I wouldn't want to do that because it should come from within you that you want to come and volunteer. And we had a lot of students, we had different, so you can come and enroll. For a brief moment, we had stopped, especially after this COVID, we had stopped this voluntary program. But now we would like to restart that and have people to get trained. First of all, we need you to get a little trained on how to handle them, go through the communication skill classes, what is it that do's and don'ts, when you're talking to a patient. Because there are a lot of information we wouldn't want you to leak out to them. Especially, most of them don't even know they have cancer, but it's so important for them to know that they, to let them know that they have cancer. So for that, we need to take it up stage by stage. So there are few things that we teach you not to discuss with the patient, but how else can you lend support to the patient? There are various ways. I know a lot of people say, no, I don't want to come to the hospital because I can't see the patient. Is there any way I can volunteer and all that? So we can just do phone calls, talk to them. I remember I had got COVID twice, and the first time, I was a COVID nodal officer in KIDWAI, and I got inflicted with COVID, and the first time I was pretty serious, and I was admitted to the hospital. It was only the conversation that kept me going with my friends, the counseling that kept me alive, I guess. So this phone calls makes a huge difference. So we have started even video conferencing with patients. You can do that. Even if you don't want to come, you can always call the patient up and do a video calling and talk to them. That itself it's a good thing. And more than the patient, I think it brings us a lot of satisfaction within ourselves that we have contributed something to society. And I feel each one of us here, we've come into this world for a purpose. We do not know, we need to check that purpose and see what is that we are here for. God has sent you here for something. You enjoy your life, but I think 10% of your time, your money, or whatever it is, you have to give it back to society. And I feel time is something that is so important. If you can give it, I'm telling you, it is going to change your attitude. You will grow better as a better person, rather than, you just spend away and while away that time with something that is really, really useless for us. You'll grow as an individual. And I feel everybody has to adopt that. Giving back to society is something that we need to learn, right? Sorry? Yeah, we will soon roll that out. Very soon we're going to have that program, so all of you can come and enroll for it. We will start off some training programs for the volunteers. We have, in fact, in Indian Association of Palliative Care, we have one program only for the volunteers. So I urge everybody to enroll for that program. It will be an online workshop. And once you're that, I think we can have you on the panel. That will be really nice. Pardon? I'll be probably try to put it up in the website, or the moment I have this, I can send it to your email or whatever. I can do that. Yeah. Usually on the website, we will announce it. But if not also, I can just get in touch with probably your HR or PR, and we can go along with it. Yeah, we can do that. So, thank you so much for the patient hearing. And I wish both Dr. Krishnappa and myself have, something that you have learned for us spending time here, something to take home, a message to take home, that if you have somebody, even if you're not smoking, you're not chewing tobacco, please, whoever you see, please tell them not to do it. And probably you can sit and, start preaching them. I remember just an incident, another one moment. I was traveling from here to Chennai. And I fought with a person because she was taking my window seat. And I said, that's my seat. She said, no, that's mine. So her attitude showed that I don't think I can fight her anymore. I just decided to sit down. And we didn't speak for 1 hour because she was very put off with me. We had a bit of an argument and all that. But later on, I decided to break the ice. when I started talking to her, and then I told her about this voluntary program and what all I do. And then she really said, I want to connect. And then today, she's one of the volunteers who's really doing wonderful work in Bangalore. Okay, and I really thank her. I'm telling you what kind of people you meet and how you can change them. You know, so she's very, very indebted to me for that. And she said, your company has really changed my life. I don't want to take credit, but I'm just telling you, do that little bit for people and it's going to really take you places, right? Yeah, thank you so much. Thank you once again for inviting me. Thank you, sir, and thank you the entire organization. It's really a wonderful, I feel really good to have come here. Thank you. Yes, please.
What's the website name?
We have KIDWAI, I'll just tell you, we've changed the website because we had to redo it. It's KIDWAI Memorial Institute at org.in. No, we can just check that out, I think. We will let you know. You can just check that out. We have just revamped that website. It had crashed, so we redid it. Please tell us. You can just go on to KIDWAI Institute. You'll get it. Yeah, please.
Hello, ma'am. My grandma had breast cancer, and it was cured. She was cancer-free, but after 1 year, she died only because of fever. But nobody know how she died. Even after being cancer-free, she died.
Okay.
And
we
is
are
there
not
any
sure whether she died
possibility
of cancer because you said she had fever.
Yeah,
So-
she just had fever. She was
When was
after
this,
1
ma?
year.
When was this?
20 years ago.
20 years ago, okay. We are not sure what exactly would have happened because if she's completely cured, her fever may not be related to cancer. It could be some other infection which probably could not be recognized and she does suddenly died. Sometimes very, very high fevers is difficult to control and the infection. So probably we need to look into it. If you have the files and things like that, we'll try to see what is. Where was she treated? In KIDWAI?
No, ma'am. It's a clinic. It's our family doctor who cured her.
Unlikely, usually a fever, unless it's a blood cancer, a fever of unknown origin it's called. It's usually related to blood cancers. Otherwise, we do not know if it is that. But for breast cancer cure and getting a fever, it's unlikely there's a connection there.
So is there any possibility that it will pass on?
Cancer is not contagious. Please remember this. It is still a social stigma in the rural areas. Okay, but cancer is not contagious. That is why we tell you to sit as a volunteer, hold the hand of the patient, talk to the patient, listen to the patient. So cancer is not contagious at all. And this is what we need to even tell people who think cancer is contagious. It can spread. It is not. In fact, we had Christ College students conduct a street play in KIDWAI, and also we had a walkathon to Lal Bagh when they conducted a street play to tell people that cancer is not contagious.
Okay, thank you.
Yeah. Oh, genetic. Yes, 10% of cancers is supposed to be genetic. If you have cancer, your aunt, your uncle, your mother, somebody had cancer, please get yourself screened. He's spoken to you already about primary prevention and screening programs. And that is why we are here today. I think the screening program is going on there outside in some hall. But yes, please get yourself screened, especially when you cross the age of 35, 40. Earlier it was 50. Now we're telling the moment you cross the age of 40, please get yourself screened, especially cervical cancers, anything that is, So you can actually come to KIDWAI. Come to KIDWAI and you can pay up a small amount, I think about 2,000 or so for a lady, 2,500 because we're going to do a mammogram for you. And that is why it turns out a little. Otherwise, with that 2,500, entire thing we do, the entire screening program we do. And 2,500 is absolutely nothing. If you go out for a meal today, for a fine dining restaurant, it just goes away for 4,000-5,000. So I think once a year, you can spend the 2,500 over your health. So I tell you, all of you, please go through health screening programs. It's just not for cancer. Go to Jaideva and get your cardiac checkup also done every year. Fix a date. I always tell, fix a date. Maybe 1st of Jan, your birthday, your anniversary, something that will remind you that you have to get your health checkup. Right? Anything else? Yeah. You can contact us anytime. Feel free. Yeah. Thank you so much. Thank you.
Thank you, ma'am, for imparting your knowledge and making us realize how dreadful cancer can be. Thank you for making us self-aware on the prevention of cancer and importance of palliative care. It was truly inspiring and heart-touching for me to see kindness and compassion towards the patients, and treating them as one of us is truly a rare sight to see. Thank you, ma'am.
Thank you so much. Thank you so much.
We have one last announcement. Saisha India Foundation, an NGO who works towards women and children cause, they would want to address us only for a couple of minutes. Kindly bear with us. They have a very interesting product.
Good afternoon. Thank you all for giving me this opportunity. I am Sita. I am here on behalf of Saisha India organization. It's a charitable trust. Along with me is Mrs. Vijaya. We'll be here for some time after this. We work with breast cancer patients, especially those who have undergone mastectomy. They feel a lot about losing their breasts, and it decreases their confidence, and their interaction with the society decreases. So we are volunteers here in this organization. All of us are volunteers, and we make these breast prostheses for those who have undergone mastectomy. These are knitted knockers. We call them knockers, knitted or crocheted knockers, and this is done in cotton yarn so that it is helpful for the skin, and it doesn't irritate the skin. And it's also not very heavy, it's washable, it can be reused, etc. So any of you who know people who have undergone mastectomy, who are in need of this, can take the pamphlets from us, and you can send an email to the organization. These are given free for the patients who have completed their treatment for mastectomy, and after 3 months they can start using these. This is founded by one Mrs. Jayashree Ratanji in 2018, and we have volunteers all over India. We do the knitting part, and then at some specific centers the filling is done and it is posted to the patient. So patients need not come anywhere. We take their details and we just post it to them and give them some instructions how to use them. So please feel free to contact us if any of you whom you know needs these, and they will contact us and we will let them have this. So thanks a lot for giving this, and it gives me great pleasure that we have been here to listen to the KIDWAI surgeon, Dr. Krishnappa, and Dr. Prabha, madam. It's very heartening to know that if we can be of some help to them. Thank you.
Thank you, ma'am, for introducing a wonderful product to us. The doctors from KIDWAI would demonstrate the technique of physical breast examination. Staff and students are requested to go in groups of 3 to 4 to the room guided by our volunteers post the vote of thanks. Additionally, we request the audience, particularly of the age 35 and above, to avail the free breast and cervical cancer screening available in the KIDWAI van at the NMKRV grounds. I finally would like to invite Professor Bhamamani BJ to deliver the vote of thanks.
Good afternoon. I feel honored and privileged to deliver a vote of thanks on behalf of RSST, NMKRV College, UG, PG Department of Biotechnology and Microbiology. BHAVANI Memorial Endowment is an example to show that we can celebrate and remember our loved ones even after their demise. In this regard, I would like to extend my heartfelt gratitude to Dr. Y. Tuljappa sir, Bhavani's father, and Srimati Purnima, Bhavani's sister, for contributing towards Bhavani Memorial Endowment Fund, and also for motivating the young minds to donate for the social cause. Thank you, sir, for gracing this occasion. I am much obliged to thank our other donors, Dr. Mrinalini B.R., Basanti, Sneha Krishnan, Gargi, Kritika Mahesh, Smita, Parvati, Sapna, Priyanka Venkatesh, who were the first batch biotechnology occasional students between 1994 to 97, and the batchmates of Bhavani for initiating Bhavani Memorial Endowment Fund. Thank you, ma'am, Krishna ma'am, for being here. One of the purpose of today's program is to create awareness about the cancer, and awareness cannot be raised without the knowledge of expertise in the related field. I would like to thank today's speakers for accepting and delivering awareness talk. I thank Dr. Krishnappa sir, HOD Department of Head and Neck Surgery, KIDWAI Institute of Oncology, for giving detailed explanation on oral cancer. Thank you so much, sir. I thank Dr. Prabha Sheshachar ma'am, Resident Medical Officer, KIDWAI Institute of Oncology, for enlightening us about the palliative care and for making us empathetic about the cancer patients, ma'am. Thank you so much. And the talk really enlightened all of us. Thank you very much for this. I'm very much thankful to Dr. Mahantesh, KIDWAI Institute of Oncology, who has been instrumental in arranging this talk and also about today's screening camp. Thank you so much, sir. He is not here now, but thank you so much, sir, he was the point of contact for us to contact the KIDWAI institution. Thank you so much for the overall arrangements being done by him. My deep gratitude to Bhima Reddy, sir, other doctors, technicians, and the supporting staffs of KIDWAI institution who are there in the bus, who are involved in screening the public. Thank you so much. My sincere thanks to our principal, Snehalata G. Nadigar ma'am, for her continuous support. I am very much thankful to our academic coordinator, HOD, Department of UG Biotechnology and Microbiology, Suman Prasad ma'am, for her constant guidance, support, and encouragement in making this event successful. Thank you very much, ma'am. I am very much thankful to all the teaching and the non-teaching staffs of UG and PG Department of Biotechnology and Microbiology for their kind cooperation. This event wouldn't have been possible without the backup by the team of motivated, dedicated, and enthusiastic students. I thank each and every one of our volunteers who took so much of initiative, involvement, and willingness in publicizing and organizing about this event. Thank you very much, girls. Without your support, this program wouldn't have been possible. Thank you for that. I thank all the teachers, students, and the public in this auditorium for being in this program and making this event successful. I would like to thank our college engineer, Tejas, our auditorium in charge, Shastri sir, and today's technicians for helping us in conducting overall this event. Thank you very much. Wishing a healthy future. Loka samasta sukhino bhavantu. Thank you.
We request the audience to stand for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, everyone.